What we presented was a 7.5-year follow-up of patients in the pooled analysis. So these are patients treated with single agent ibrutinib, 370 of them across 3 trials. So we've now got 7.5-year follow-up, and there are a proportion of patients who are still taking the drug, so it's fewer than 10%, but they're still on drug. The important thing is, in that group of patients it remains active, there are no new side effects, which is good for patients. Perhaps the most important thing we did with this analysis is we looked at the outcome with the ibrutinib compared with the outcome with their previous therapy. What we know with mantle cell lymphoma is when you treat with chemotherapy, you get your best response. When you use chemotherapy again, it's not as good. It's common with many lymphomas. But when we looked with ibrutinib, what we found was the overall benefit from the ibrutinib was better than what we'd seen with the prior therapy if you take the whole group together. That was most striking in the patients that had got the best response with chemotherapy. So these are the patients where clinicians are more inclined to give chemotherapy again. So they give chemotherapy, they get very long responses, so over 2 years, so then they're more likely to use chemotherapy again. So what we found was that group gets the most benefit from the ibrutinib. So the benefit is more than a year longer than they had with the chemo. So I think this sort of tells us quite clearly that we should be using this drug at first relapse, even in the patients that get the best response to chemotherapy. So I think that's the key message really from that analysis.